Okay. Okay. I'm starting now. Okay. Okay. I'm starting now. Good evening, my dear PWNs. Today we are going to discuss some important questions that can be asked, that are all the potential questions in our INI-CET. I have incorporated certain case scenarios. Majority of them are case scenarios, and many pictures were also incorporated so that you can get a bird's eye view. So logically we are going to discuss about some cases, some case scenarios, and these case scenarios will be covering many other sub questions, so that we are going to discuss about only 10 questions, but those 10 questions are definitely going to cover additional many questions along with the existing one that you are going to solve right now. So going to our first question. They are adjusting something. Let me see. Okay, then. Shall I proceed? Team PW, shall I proceed? Okay, then. So going to our question number 1. So what is this question? Let us see. Let me stay away. Done. What is this question? A 10-day-old newborn born by labor natural and cried at birth, brought with tachypnea. On examination, respiratory rate is 60 per minute, minimal retractions, no grunting, no cyanosis, and air entry reduced in the left infraclavicular and infraaxillary area. The diagnosis is, the X-ray is shown here. The diagnosis is 1. Congenital lobar emphysema, 2. Pneumothorax, 3. Meconium aspiration syndrome, 4. Congenital diaphragmatic hernia. So this is the X-ray you are going to discuss. And what is this is a 10-day-old newborn brought with respiratory distress, and there is no history of birth asphyxia, and the respiratory rate is 60 per minute, minimal retractions, no cyanosis, nothing. Look at this X-ray first and tell me your differential diagnosis. What are all the differential diagnoses that can be offered in this case? The differential diagnoses that can be offered in this case are 1. Congenital lobar emphysema. Let me go away. 1. Congenital lobar emphysema, 2. Pneumothorax, 3. Meconium aspiration syndrome, 4. Congenital diaphragmatic hernia. And it was discussed in our FMGE section just 2 days back. If someone who had not listened to that video, you can just go and listen to that video. In that video, we had described about an approach to respiratory distress in newborn. So what about in this case scenario? Can anyone tell me, is it a case of lobar emphysema, or is it a case of pneumothorax, meconium aspiration syndrome, or congenital diaphragmatic hernia? Can anyone tell me? So those who have not listened to my previous section on FMGE can have a simple rapid bird's eye view. So what is that bird's eye view? Whenever you have a So whenever you have a neonatal respiratory distress, a simple 5-minute revision, neonatal respiratory distress, what you need to do? You need to see whether it is a simple revision, whether you need to see whether it is a term baby or it is a preterm baby, because there are so many differences with respect to the gestational age at birth. If it is a term baby, then you need to see whether it is the onset of respiratory distress is less than 6 hours or more than 6 hours. In the same way, in preterm, whether it is less than 6 hours or more than 6 hours. More than 6 hours. If it is more than 6 hours in both term and preterm, you have only two things. If the child is having large liver span, having large liver span, you need to think in terms of congenital heart disease. You need to think in terms of what? Congenital heart disease. Think in terms of congenital heart disease. When you have shock as a manifestation, you need to think in terms of sepsis. You need to think in terms of sepsis. And if in a term, if it is less than 6 hours, what are all the differential diagnoses that you can offer? Term baby less than 6 hours, what are all the differential diagnoses you can offer? The differential diagnoses are then term baby less than 6 hours, then you need to see whether it is a sick baby or well baby. Sick baby or well baby. Alright, if it is a sick baby, either it can be due to meconium aspiration syndrome or it is a case of HIE stage 2. You all know that HIE stage 2 is a hypoxic ischemic encephalopathy in a term baby, and is characterized into 3 stages: Sarath and Sarath staging, HIE stage 1, 2 and 3. HIE stage 1 is characterized by sympathetic output, whereas HIE stage 2 is characterized by parasympathetic output. This increased parasympathetic output can lead to increased respiratory secretions, as a result of which you can get respiratory distress in HIE stage 2 in a term baby. If it is a well baby, you have two reasons. One is transient tachypnea of newborn. Second one is polycythemia. These are all the medical conditions associated with the respiratory distress. And if it is more than 6 hours in case of, and if it is more than 6 hours in case of, in term it is more than 6 hours, in preterm more than 6 hours, causes are one and the same. Whereas when it is preterm less than 6 hours, what are all the causes? Only two causes. What are all the causes? Only two causes. One is hyaline membrane disease. The second is hypothermia. One is hyaline membrane disease. The second is hypothermia. So this is the approach to respiratory distress in a newborn. And it was discussed in our topic that in case of term, you will use Downey score. In case of term, you use Downey score, and in preterm, you use Silverman-Anderson scale. Okay, now, so this is the approach to respiratory distress in newborn. Remember, all these causes are, I repeat, all these causes are medical conditions. What are all the surgical conditions? Not only this, there are also some surgical conditions which can lead to respiratory distress in newborn. What are all the surgical conditions? Let us see. Let us see what are all the surgical conditions. The surgical conditions are, let us discuss in a clinical way the surgical conditions for neonatal respiratory distress. What are all the surgical conditions? Let us see. 1. Whenever any child with, so let me put it as a case scenario. A term baby, respiratory distress since birth, and there is frothing since birth, and there is frothing from the mouth, and the child is having cough while taking breast milk. Invariably, what is the diagnosis? The diagnosis is tracheoesophageal fistula. The diagnosis is tracheoesophageal fistula. Remember, what is the next step that you need to do? You need to put an NG tube and you need to take an X-ray. Never ever take an X-ray without an NG tube in situ in cases of neonatal respiratory distress. And if you see a coiling of tube in the neck, it indicates it is a case of tracheoesophageal fistula. Remember, this coiling present can be a tracheoesophageal fistula, but sometimes coiling may not be seen. Still it can be a case of tracheoesophageal fistula. How it can be? Yes, H-type fistula. In H-type fistula, there will not be any coiling of NG tube in the neck. Despite that, still you can consider tracheoesophageal fistula, but it is usually an H-type fistula, often present as recurrent pneumonia in an infancy. So surgical conditions 1. Second surgical condition. What is the second surgical condition? The second surgical condition is, let me say, it is a term baby. The child is having respiratory distress since birth. Second point, it has got a scaphoid abdomen. Then air entry reduced in the chest. Either in the right or in the left. Air entry reduced in the chest. Next point, apart from that, what else you can have? You can hear gurgling sounds in the chest. Okay, so what is this? You all know this is a case of congenital diaphragmatic hernia. Okay, congenital diaphragmatic hernia. If you take an X-ray chest including abdomen, what are all the things you can see? You can see coils of intestine. In chest. Along with that, there will be absence of border of diaphragm. Absence of diaphragm border. That's why in any case of respiratory distress, you need to find out whether the diaphragm is through to through. From wall to wall it is present or not. So this is a case of congenital diaphragmatic hernia. And what are all the other questions can be asked? Usually nowadays many people are going, not all, almost many people are going for antenatal anomaly scan. In anomaly scan itself they can find out. But if there is a congenital diaphragmatic hernia present, what will happen? It will lead to lung hypoplasia. As a result of which, the child can go for pulmonary hypertension. That is a long-term sequelae. Then a mother can ask you whether if it is detected in the antenatal period, the mother can ask you, Sir, after childbirth, you told that my child is having congenital diaphragmatic hernia and the lung is occupied by small intestinal loops and the lung is not growing. After birth, how my child is going to perform because of this poor growth of lung? Is there any prognostic factors to say? The prognostic factors are: one is poor prognostic factor. I repeat, poor prognostic factors. Poor prognostic factors. What are all the poor prognostic factors? 1. Presence of liver in the chest. Presence of liver in the chest is a poor prognostic factor. Second point, lung head ratio. The ratio of lung versus head ratio. If it is less than 1, that means your chest is lung head ratio if less than 1. These are all the poor prognostic factors. Whenever mother asks whether my child will be doing well or not, you need to say, you need to look for presence of liver in the chest and you need to look for lung head ratio less than 1. And remember, apart from X-ray chest, even before taking a CT chest, take a USG chest. Nowadays, USG chest has been used like anything and it is replacing your CT chest. When you take an USG chest, the intestinal columns will be well visible and also the diaphragm outline, whether it is visible or not, you can see. Okay, so these are all the surgical condition. The first surgical condition is tracheoesophageal fistula. The second surgical condition is congenital diaphragmatic hernia. But the third condition, which is often not told and often you are not exposed, is congenital lobar emphysema. What does it called as? Congenital lobar emphysema. Third condition is congenital lobar emphysema. So what is this congenital lobar emphysema? In congenital lobar emphysema, there will be an intraluminal block. There will be an intraluminal block in the bronchus, as a result of which air goes into the alveoli during inspiration but cannot come out, can't come out because expiration is a passive process. Come out, leading to distension of alveoli, But right now there is no destruction of lung wall. But in adults, emphysema means there is destruction of adult wall. Here there is no destruction of adult wall, no destruction of alveolar walls. That's why the congenital lobar emphysema nowadays is replaced by, what is the new term called as? Congenital hyperlucent lung. This is called congenital hyperlucent lung. The new term for congenital lobar emphysema is congenital hyperlucent lung. And what are all the manifestation? This is non-functioning alveoli. Even though there is no destruction of alveolar wall, this is a non-functioning alveoli. So what happens? Air entry will be reduced. Second, because of the distension produced by the emphysematous lung, there will be mediastinal shift towards the opposite side. There is mediastinal shift to opposite side. And the next point is the underlying lower lobe will be collapsed. The underlying lower lobe is collapsed. What is the treatment of choice? In severe cases, remove the part of the lung, remove the affected lung. In severe cases, in mild cases, mild respiratory distress, no need to treat. In severe cases, remove the affected lung segment. That means left upper lobe. Left upper lobe. Now, we have discussed about some medical causes and we have discussed about some surgical causes. Surgical causes are congenital diaphragmatic hernia, tracheoesophageal fistula and congenital lobar emphysema. That's it. 3 cases. Done. Let us come to this case. Why I am asking it again and again? Because this question was asked almost thrice between 2015 to 2020 in AIMS. Right. So what is this case? If it is a, okay, let me see, assess this X-ray. Look at this. When you compare the right lung with the left lung, compare the volume of the right lung. Let us see. The volume of the right lung is very small, whereas the volume of the left lung is huge. Point number 1. Left lung is huge. So the left lung is bigger compared to a right lung. Second point. Look at this. The left lung also, look at this. Compared to the right lung, the left lung is hyperlucent, more air in the alveoli. The left lung is hyperlucent. Look at this, more air in the alveoli. Hyperlucent. Second point. Third point. Apart from that, as I told you already, because of the emphysematous lung, there is a mediastinum. The heart is pulled to the other side, the right side. And finally, look at the compressed lower lobe. So, this lung is large. This lung is, point number 1, left lung is large. Point number 2, it is hyperlucent. 3. Mediastinum shifted to opposite side. And finally, fourth point is collapse of the ipsilateral lower lobe. So this is a case of congenital lobar emphysema. Why can't it be a pneumothorax? In pneumothorax, usually occurs in mechanically ventilated children and usually arises as a result of meconium aspiration syndrome. Here there were no history suggestive of meconium aspiration syndrome, no history suggestive of meconium aspiration or mechanical ventilation. And apart from that, look at this. In pneumothorax, air is getting collected in the pleura so that you can't see a vascular marking. But in congenital lobar emphysema, air is getting collected in the alveoli so that you can see a pulmonary vessel. Here, these white structures that are seen are pulmonary vasculature. If you see a pulmonary vasculature in a underlying black or hyperlucent lung, think of emphysematous. Think of congenital lobar emphysema. If those pulmonary vasculature is not seen underlying with the background of black lung, then your diagnosis should be pneumothorax. Here pulmonary vascular markings are seen. So why not pneumothorax? No history suggestive of meconium aspiration, no history suggestive of mechanical ventilation. Pulmonary vasculatures are not seen. Again, meconium aspiration syndrome, there is no such history indeed. And finally, is it a case of congenital diaphragmatic hernia? Look at this. I could see a beautiful diaphragm from here to here, and I could see a beautiful diaphragm from here to here. As a result of which, my diagnosis is not congenital diaphragmatic hernia. So what is this again? Spotter. The one on the left side, just now we have taught you So what is the one on the? So this is a case of congenital lobar emphysema, CLE. So what is the one on the right side? What is this? What is this? Just now we told you what is this. Can anyone tell me what is this? You can trace the diaphragm border from here to here, but here where you could trace your diaphragm border and you can see multiple lystics loosened spaces in the right lung. So what is this? This is a case of right-sided congenital diaphragmatic hernia. Compared to the left side, right side is less common because liver is occupying the right side of the diaphragm. In between your chest and your abdomen, liver is occupying below the diaphragm. As a result of which you will see liver more on the right side and intestinal loops on the right side. Here you could see intestinal loops on the right side. Again a case of right-sided congenital diaphragmatic hernia. The presentation is a newborn term born by labor natural, cried immediately after birth, developed scaphoid abdomen and respiratory distress. Why scaphoid abdomen? All intestinal loops are going into the chest, as a result of which you get a scaphoid abdomen. And what else? As you know, bag and immediately as soon as the child is born, whenever you suspect, you need to put an NG tube to decompress the intestine, because the intestine are occupying the chest where the lung is present. When you put an NG tube, you are decompressing the intestinal loops that are present in the lung. So NG tube insertion is the first thing that should be done whenever you suspect a case of congenital diaphragmatic hernia. Next point. Bag and mask is contraindicated. Bag and mask is contraindicated. Why? Why bag and mask is contraindicated? Whenever you do a bag and mask ventilation, majority of the air, apart from going into the trachea, it will go into the esophagus and intestinal loops, leading to increase in the respiratory distress. So instead of bag and mask, you need to opt for bag and tube ventilation. You need to opt for bag and tube ventilation. That means you need to put an endotracheal tube and attach the bag and attach the ambu back to the endotracheal tube. So these are all the questions that we have discussed, with one particular question, that is respiratory distress in newborn. And the spotters that can be asked are congenital diaphragmatic hernia, or congenital hyperlucent lung, or congenital lobar emphysema. And the differences we have discussed in detail, how to differentiate between these two. Remember, definitely you will be having one question from this: respiratory distress in newborn. Okay? Let us go to the next question. Let us go to the next question. So let me read. So first question itself took more than 20 minutes, but let it be. What is the second question? A 10-year-old child brought with fever and cough for more than 2 weeks and weight loss of more than 500 grams. There is no positive contact history for TB. The child is referred. The X-ray is shown here. The next best thing is 1. Trial of antibiotics. 2. CB naught in the sputum. 3. Sputum for AFB smear. And 4. Sputum liquid culture for TB. Let me wait for your answer. This is a case of suspected presumptive pulmonary TB with an X-ray shown here. X-ray shown here, and how you are going to proceed. Let me wait for about 30 seconds and waiting for your answer. Waiting for your answer. Someone has asked Akhil Tota whether bag and mask ventilation in meconium aspiration syndrome Bag and mask ventilation in previous guidelines were contraindicated in meconium aspiration syndrome. Right now, whether it is meconium aspiration present or absent, all birth asphyxia babies at the end of 1 minute of tactile stimulation with respect to your drying, stimulation, etc. At the end of 1 minute, if the heart rate is less than 100 per minute, if the heart rate is less than 100 per minute, you need to start your bag and mask ventilation, whether it is a case of meconium aspiration or not. So right now, for bag and mask ventilation, meconium aspiration syndrome is not a contraindication. So two of meconium aspiration, okay, 2 of my kids have opted for BB. So what is the answer? BB. Okay, so my kids are going for the choice sputum for CB not. Shall we discuss, my dear children? Yes. Okay. Okay. See, this sessions are mainly to stimulate you, mainly to concentrate on certain questions that are potential questions that can be asked, because pediatrics is such a old subject. Okay, we are just sensitizing you with some important questions. That's it. Okay, right. For detailed things, we will be discussing a 40-hour pediatric question discussions in our PW session. This is just to sensitize you to concentrate on certain important questions. Done. So my kids are opting for CB not. But my dear kids, what is the answer? Look at this. Can anyone tell me what is the thing that you are seeing here? Yeah. Opacity present in the left upper lobe. Opacity present in the left upper lobe. And opacity is present in the left upper lobe. So is it correct or not? And opacity present in the upper lobe. So is this a case of pulmonary tuberculosis? Is this a case of pulmonary tuberculosis? Tell me, is this a case of pulmonary tuberculosis? Okay, let me give you a simple discussion. When you need to suspect your pulmonary TB, you are seeing a consolidation occupying the left upper lobe. So what are all the options, or what are all when you need to consider a case for TB? When fever lasting for more than 2 weeks? Maybe, yes sir. Let me see. When fever lasting for more than 2 weeks? When cough lasting for more than 2 weeks, fever lasting for more than 2 weeks, cough lasting for more than 2 weeks. Apart from that, if you have a weight loss, now rapid fire revision of 10 minutes of entire pediatric TB, you will be getting one question from this, I bet. So weight loss of more than how much? 5% in the past 3 months. And a positive contact. Contact means it is a person who took ATT for pulmonary tuberculosis. ATT for pulmonary tuberculosis within 2 years from now. So this is the index case for TB. Now with this index case, you need to go for X-ray chest. When I have a case like this, you need to go for X-ray chest. In X-ray chest, I will find out 3 patterns, my dear friends. Well, yes, here weight loss is present. 3 patterns. What are all the 3 patterns? One is mediastinal node. Second is cavity, a lucency in the white area, that is called cavity. Third is miliary mottling, things, white things throughout the entire lung, that is called miliary pattern. When any one of these are present, you need to go for CB naught. You need to go for CB naught. So what are all the samples that can be used for CB naught? What are all the samples that can be used for CB naught? One is expectorated sputum. One is expectorated sputum. Second one is induced sputum. Third one is GL or otherwise known as gastric lavage. Third one is gastric lavage. One is expectorated sputum, second is induced sputum, third one is gastric lavage. Most commonly we use gastric lavage. So what is gastric lavage? You need to put an NG tube in the night itself. In the morning, even before the child wakes up, you need to aspirate the contents of the stomach because the child would have swallowed sputum. The sputum may contain tuberculous bacilli, and you need to take any one of these sample and subject it to for CB naught. In CB naught you will get two results. One is MTB detected or not. One is MTB detected or not. Second one is MTB detected or not. Second one is R resistance detected or not. R resistance detected or not, yes or no. MTB detected, yes or no. When you have this MTB detected, then it is called as, and R is sensitive, R resistance is not present, it is called microbiologically confirmed TB. Microbiologically confirmed TB. Confirmed TB. TB. When you have these three findings, go for CB naught. Then one might ask, sir, it doesn't contain any one of these following. I will show, my dear boy. I am going to show you the X-ray picture itself so that you can understand from the real images rather than these three theories. Okay, when these things are absent, the X-ray is not suggestive of mediastinal adenopathy. The X-ray is not suggestive of cavity. When the X-ray is not suggestive of miliary pattern, then you need to give a trial of antibiotics. You need to give a trial of antibiotics. Trial of antibiotics, because these are all the TB specific X-rays, mediastinal adenopathy, cavity and miliary pattern. When you have TB specific X-ray, go for CB naught either from expectorated sputum, gastric lavage or induced sputum. When these X-ray findings are absent, go for trial of antibiotic. That's it. Okay. If the trial of antibiotic doesn't work, or still even when your CB naught is negative, still you suspect TB, go for indirect test. Go for indirect test. These are all the direct tests. Go for indirect test. So what are indirect tests? Indirect test will find a TB infection. Indirect test will find TB infection. What are all the tests? There are three tests. One is Manto. Second one is IGRA, interferon gamma release assay. Third one is CTB test. This Manto test is cheaper, economical, and it is less specific because it can be positive for non-tuberculous infection also, non-TB mycobacterium, atypical mycobacterial infections also. So it is less specific. Okay, what is IGRA? IGRA is interferon gamma release assay. I repeat, in Manto you will find the macrophage. So what happens? What is the basis for Manto? You put purified protein derivative into the skin, 0.1 ml, and if the person is sensitized to TB, it will attract Th1 cells towards the site. This Th1 in turn will secrete interferon gamma, and this interferon gamma will attract the macrophage, and macrophage will produce an induration. And if the induration is more than 10 millimeter in case of immunocompetent, and more than 5 millimeter in case of immunocompromised, then it is called positive manto. Positive manto just indicates that the child is infected. It doesn't confirm the disease. Second one is IGRA. What is IGRA? Look here, the Th1 is going to produce interferon gamma. This interferon gamma is assessed or assayed by some test. Okay, this is called interferon gamma assay. This is the only test which uses blood. Important MCQ that was asked 4 years back. Which test will utilize blood? Because no other test will involve blood as a sample. The only test which involve blood as a sample is IGRA, interferon gamma release assay. This is called as what? IGRA. And here what they will do, they will take the patient blood. And that blood will be added with INI-CET and CFP. What are INI-CET and CFP? They are TB specific antigen, and they will assess the interferon gamma levels. And here this is costly since we use TB specific antigen such as INI-CET and CFP. It is specific. And the third test that is going to come is CTBC for Copenhagen. Here they had incorporated the principles of Manto and principles of IGRA. So what is the principle of Manto? You measure what? You measure the induration. But instead of injecting purified protein derivative, they inject INI-CET and CFP so that it becomes cheap, and also it becomes specific because you use TB specific antigen, and an induration of more than 5 millimeter is turned as positive. So whenever you suspect TB despite CB0 is negative, go for indirect test. So these are all the direct test and indirect test. Let us go to the question per se. The child is having, is it okay, my dear boys and girls? Is it okay for you right now? You could understand the principles and concept now? If yes, I will proceed. Okay, here fever of more than 2 weeks satisfies the criteria. Cough for more than 2 weeks satisfies the criteria, but there is no positive contact history, and there is a weight loss. Here I had given an X-ray picture. Is it TB specific? X-ray picture. Before going to that, let me again show you what are all the TB specific X-rays. So these are all the TB specific X-rays. Are you there, my dear boys and girls? Okay, yes, Vinith. Right, so look at this. This is called cavity. You could see some. This is called cavity. So this is a cavity. Look at this is white. Inside the white you have a INI-CET. INI-CET means I don't think you need to know the explanation for INI-CET. INI-CET and CFP are TB specific antigens. That's it. Okay. So this you can see a radiolucent or black area inside a consolidation. This is called cavity. This one is called cavity. Second one, look here, the mediastinum is widened. This is called hilar adenopathy. Second one, this is called hilar adenopathy. Third one is multiple numerous nodular shadows. Multiple numerous nodular shadows. This is called miliary mottling. Miliary mottling. When you suspect a TB case and if you have a TB specific x-rays, then you can directly subject the sputum sample, whether it is induced sputum or gastric lavage or expectorated sputum for CB0. But in our case, is there any cavity? Is there any lucent area? No. Is there any hilar adenopathy? No. Is there any miliary mottling? No. So this is non-TB specific X-ray. This is non-TB specific X-ray. Whenever you have a non-TB specific X-ray, what is the next thing that should be done? Is it sputum for CB0 or something else? Let me wait for the answer. Let me wait for the answer. Let me wait for the answer. Anyone? I am looking into the chat box. This is not a TB specific X-ray. If this is not a TB specific X-ray, then you need to find out what? Akhil, Vinita, is it sputum? This is not a TB specific X-ray. Look at this. When fever of more than 2 weeks, cough for more than 2 weeks, weight loss, contact, whether TB specific X-ray is present. If TB specific X-ray, CB0. If there is no TB specific X-ray, what is the answer? Trial of antibiotics. If the trial of antibiotic doesn't work, then you need to go for indirect test. Vinita and Akhil, this is, look at this. When I have a TB specific X-ray, I will go for CB0. When TB specific X-ray is not there, I will give trial of antibiotic. If the trial of antibiotic doesn't work, then I will go for indirect test. Okay, Akhil Tota has asked for culture. Wait, my dear boy. If my indirect test is positive, what does it mean? If my either Manto is positive or IGRA is positive or your CTB test is positive, then the child is TB infected. Then as per Akhil, if TB is infected, despite that antibiotic is not working and indirect evidence for TB is present, now I will subject the child both for repeat CB0. Then I will again do whether my first CB0 has detected or not. Again, if it is positive, I will start ATT and I will say it is a microbiologically confirmed TB. Sir, if CB0 is negative, what will you do? Very, very simple. Still the child is Manto positive. Manto positive and also antibiotic failed. Now what I will do? I will start ATT, but here it is called clinically diagnosed TB. But before starting ATT, I will send the sample for as my ATT. Akhil, just now I am coming now. If Manto is positive, antibiotic are failed, but still I will start ATT. But before that, as Akhil Tota told, I will send for culture because culture is more sensitive and can pick up the bacteria compared to your compared to your CB naught. In culture, you have two types of culture. One is solid culture and another is liquid culture. Solid culture is called LJ, Lowenstein-Jensen medium, and here it will take a minimum of 12 weeks for growth. So it is not a point of care test. So I will take liquid culture. What is called liquid culture? MGIT, Mycobacterial Growth Indicator tube system, and this is the gold standard test right now. This is the gold standard test right now. MGIT, Mycobacterial Growth Indicator tube system. That's it. With this, almost we have finished many things in TB. What are all the things we have covered? Fever, 2 weeks, cough, 2 weeks, weight loss, 5% in the past 3 months, contact who took ATT for pulmonary TB in the past 3 months, in the past 2 years. First MCQ. Second MCQ, I will look for second step is X-ray chest. If X-ray chest shows cavity bar hilar adenopathy bar miliary mottling, I will go for CB naught. If there is no cavity, no mediastinal adenopathy, no miliary pattern, I will go for trial of antibiotic. If trial of antibiotic failed, I will go for indirect test, Manto or IGRA or CB naught, Manto or IGRA or CTB test. If it is positive, again I will send the sample for CB naught. If it is negative, still I will start ATT, but I will send the sample for liquid culture because it is more sensitive to pick up a Mycobacterium tuberculosis. So you have microbiologically confirmed TB, start ATT if CB naught is positive. You can start ATT despite you have CB naught negativity if Manto is positive and the child is not responding to a trial of antibiotic, but here you will call it as clinically diagnosed TB. Okay, is it okay, my dear boys and girls? Here, what is the duration of treatment? 2 HRZT. 2 means what? 2 months of IP intensive phase. IP intensive phase. 2 months of HRZT. INI-CET daily, rifampicin daily, pyrazinamide daily, ethambutol daily, followed by continuation phase, that is 4 months of HRE, that means daily isoniazid, rifampicin and ethambutol. So this is the new guidelines with respect to pulmonary tuberculosis. Okay? New thing with respect to pulmonary tuberculosis. So 6 months of treatment, 2 months of daily treatment and 4 months of HRE. And one more question that can be asked, each and every patient who are getting ATT should be registered in an app called NEET app by the government, central government of India, so that each and every patient details will be entered in that app. Anyone in India from anywhere can trace whether the patient is taking ATT or not, whether it is a microbiologically confirmed TB or it is a clinically diagnosed TB. Anyone can trace the details of the person who received ATT from any part in India. That is called NEET app. Again, one more entrance MCQ that can be asked. Is it okay, my dear boys and girls? So second question is over. Okay. Done. Third question. So what is this third question? Let me go to the third question. Shall I, my dear boys and girls? A 4-day-old newborn brought with lethargy and refusal of feeds for the past 24 hours. A 4-day-old newborn brought with lethargy and refusal of feeds for the past how many days? 24 hours. Born by labor natural, cried immediately after birth, and the child is on exclusive breastfeeding. Because when the child is given some other feeds apart from breast milk, you can think about something else. His rapid sepsis screen is negative. That means what? Rapid sepsis screening is negative. Okay, negative. Rapid sepsis screen is negative. Someone is asking what advice you want to give with respect to NEET. Just listen to, do not read new things, just revise whatever you have read. Okay, have a good sleep for about 6 to 7 hours per day. Have a small nap in the afternoon. Okay, have a good walk of about 40 minutes in the morning. So remaining 10 to 14 hours, just revise what are all the things that you have read. Never ever concentrate on new things. Okay? But that's it. And also, if you have time, and kindly look into our direct live YouTube classes, because we have selected certain basic questions that were repeatedly getting asked in your INICET previously. Okay? Done. So our rapid sepsis screening is negative. Blood and CSF culture did not grow any organisms. No skin lesions or abnormal urinary order. Possible diagnosis is because almost between 2010 to 22, almost 10 to 15 times that questions have been asked. 10 to 15 times that questions have been asked. So what is this? Okay, done. I am waiting for your answer, my dear boys. Damn sure question with respect to INICET. Inborn errors of metabolism, acute inborn errors of metabolism. At least one case you will be getting. I will be waiting for your answers for about 30 seconds from now. Waiting for your answers, my dear boys and girls. Answer C, glutaric aciduria. What else? Let me be. When you want to answer something, you need to know the logics and reasons behind those answers. Vinita, multiple carboxylase deficiency. One more, opted. Many has opted for. Yes, I have two answer C's and one answer B. And shall we go for an approach? My boys, are you ready? Simple 5-minute explanation on approach to inborn errors of metabolism. Shall we go, my dear boys and girls? Yes. Let me proceed. It's very easy, man. It's very easy. So what do you mean by inborn errors of metabolism? Let me explain to you a simple concept. What happens whenever, let me explain with respect to phenylketonuria. For example, phenylalanine is converted into tyrosine. With the help of phenylalanine hydroxylase. What happens? This phenylalanine is present in the breast milk. Let us presume that the baby is not having phenylalanine hydroxylase. As soon as the baby is fed on exclusive breastfeeding, the breast milk that contains this phenylalanine should be digested, should be converted to tyrosine by phenylalanine hydroxylase in the baby. If the baby is devoid of this phenylalanine hydroxylase, what will happen? This phenylalanine cannot be converted into tyrosine. As a result of which, phenylalanine will be increased in the baby. Phenylalanine will be increased in the baby and your thyrosin will be decreased. Your thyrosin will be decreased. What are all the effects of this increased phenylalanine? This phenylalanine causes injury to the brain, as a result of which the child will be having microcephaly. The child will be having microcephaly. The child will be having mental retardation. The child will be having autism-like behavior and aggression. This is because of increase in substrate, whereas decrease in product. What is the product? Thyrosin is decreased. From thyrosin, you must have heard from our discussions from biochemistry, thyrosin is converted into melanin. Since there is low thyrosin, melanin will be low. Melanin will be low. Melanin is responsible for pigmentation of the skin. So when melanin is low, you have hypopigmentation. You have hypopigmentation leading to albinism. Leading to albinism. Leading to albinism. So what is the manifestation? The manifestation is increase in substrate as well as decrease in product, leading to manifestations of the phenylketonuria. Okay, baby? Phenylketonuria. So leave it then. Now let's come to acute inborn errors of metabolism. What do you mean by acute inborn errors of metabolism? Very simple. So acute inborn errors of metabolism. Acute inborn errors of metabolism. See, even though less questions we are discussing right now, we are discussing certain topics as a whole. So instead of knowing some small facts about many things, have a certain solid concepts behind the commonly asked questions. Okay? Right. So acute IM, when you need to consider when any infant, okay, I repeat, when any infant, point number 1, develops, what are all the, rapidly worsens in the form of what? Worsens in the form of what? In the form of lethargy, refusal of feeds, intractable means uncontrollable, intractable convulsions. One second. Ma class la irukken, phone vinga na pandren. I am extremely sorry. Okay, so intractable convulsions. 1. Intractable vomiting. All because of what? Because of increase in the unusual substrate. Increase in convulsion, increase in vomiting. And intractable hypoglycemia. My dear students, this pented, what is this pented symptom? This pented symptom is unexplained lethargy, refusal of feeds, convulsion, vomiting, hypoglycemia. Whenever you find in an infant who is born of consanguineous marriage, Why consanguineous marriage? Because majority of inborn errors of metabolism are autosomal recessive. In fact, you all know that enzymatic disorders are all autosomal recessive in nature. So in the background of consanguineous marriage, when hypoglycemia. So that we will discuss later. I don't have time. Yes, anything can come among these 5. When these things are come, what is the next step you need to do? My dear boys and girls, the next step that you need to do is always rule out sepsis. Because whatever you say, sepsis is the most common thing that is responsible for worsening of a newborn baby. So how to rule out sepsis? The sepsis can be ruled out. 1. Rapid sepsis screen. Second one is culture. Culture. What culture? You can do a CSF culture. You can do a blood culture. Blood culture. Third one, you can take an X-ray chest to look for pneumonia. So when X-ray chest doesn't reveal any pneumonia, when blood culture, your CSF culture doesn't grow any organism, when your rapid sepsis screening like absolute neutrophil count, total count, neutrophil band ratio, ESR, CRP are all not suggestive of any microorganism or infection, then you need to suspect your inborn errors of metabolism. TK, my dear boys and girls, is it clear for you? Is it clear for you? Whenever you have a pented off lethargy, refusal of fits, I'm just looking into the YouTube chat, that's it. Lethargy, refusal of fits, intractable vomiting, intractable convulsions, and intractable hypoglycemia. The first thing is you need to rule out your sepsis by direct test and indirect test. Direct test are culture and indirect test are X-ray, neutrophil count, total count, neutrophil band ratio, ESR, CRP. When all these are not suggestive of any microorganism, then consider your inborn errors of metabolism. In the next 2 minutes, we are going to see an approach. That approach is going to fetch you definitely one question. I repeat, I bet. Shall we go, my dear boys and girls? Shall we go? Yes. The first thing that you need to do is neutrophil band ratio. Mature neutrophils. How many mature neutrophils? How many immature neutrophils? Immature neutrophils. Immature neutrophils will have bands. So when you have more than 20% immature neutrophils among the total neutrophils, it means the bone marrow is ejecting more and more neutrophils. When does a bone marrow will eject more and more neutrophil? Whenever there is an evidence of infection. So that's why it is an indirect test. Okay, my dear? Okay, done. So then comes an approach. My dear students, listen carefully. What is the approach? The approach is the first investigation in any case of suspected inborn errors of metabolism is ammonia. I repeat, the first investigation that you need to take in any cases of inborn errors of metabolism is serum ammonia. And you need to look for whether ammonia is normal or ammonia is high. Ammonia is high. Okay? When ammonia is high, you need to look for three things. When ammonia is high, you need to look for two things. What are all they? One is acidosis is there or not. Second one is ketosis is there or not. Ketosis is there or not. Acidosis, look for the pH. Ketosis, you need to look for the blood ketones or urine ketones. So acidosis. So I have three things: acidosis, ketosis, elevated ammonia. Three things I will see. Based on that, I will have three permutations and combinations. What are all those permutation and combinations? First, acidosis present, ketosis present, ammonia is elevated. When acidosis is there, ketosis is there, ammonia is there, then it is called organic aciduria. Second, when acidosis is present, ammonia is present, but ketosis is absent. This is the most common MCQ. In the absence of ketosis, always think in terms of fatty acid oxidation disorder. Think in terms of fatty acid oxidation disorder. And finally, acidosis is absent, ketosis is absent, but ammonia is sky high, then it is urea cycle disorder. Urea cycle disorder. It is urea cycle disorder. So with this permutation and combination, you can find out 3 types of inborn errors of metabolism. Now, among that, organic aciduria. When you have a combination of acidosis or ketosis or hyperammonemia, your diagnosis, or is it okay for okay, my dear students? Just remember, okay, I cannot go deep into the biochemistry right now. Now, if I have a case of organic aciduria, which is characterized by acidosis, ketosis and hyperammonemia, then approach to organic aciduria. So, what is the approach to organic aciduria? Let me say, what is the approach to organic aciduria? 1. Whenever I suspect an organic aciduria because of the combination of acidosis, ketosis and hyperammonemia, then I will look for skin manifestations. Okay, whether it is present or absent. Skin manifestation presence. Skin manifestations means eczema. Skin manifestations means dermatitis. Skin manifestations means alopecia. One is alopecia and another is dermatitis. Whenever you have an acute worsening with alopecia and dermatitis, invariably the diagnosis is multiple carboxylase deficiency, or otherwise biotin deficiency, or otherwise known as biotin, which is due to biotin deficiency. Okay, yes, all will come in organic aciduria, both acidosis, ketosis as well as hyperammonemia. This is one. Whether if you have an organic aciduria, look for alopecia, dermatitis, which if it is present, it is a case of multiple carboxylase deficiency, which can be treated by giving biotin. Second one, if you don't have alopecia dermatitis, then search for abnormal urinary order. Just 4 days back we have discussed about different types of abnormal urinary order. So when you have an abnormal urinary order, then it can be glutaric aciduria, or it can be isovaleric aciduria. Both are characterized by sweaty feet odor. So either you need to search for a skin manifestation or you need to search for an abnormal urine order. Now I have a third one in which I neither had no urine order nor neither had abnormal urinary order nor your skin manifestations, then you have 2 diagnoses. One is methyl malonic aciduria and another is propionic aciduria. That's it. Over. Okay. Another is propionic aciduria. So this one picture I bet will fetch you 1 MCQ. This one picture definitely will fetch one MCQ in INICET, I bet. Okay? And finally, sir, if ammonia is normal, you didn't say anything. If ammonia is normal, let me go to this. If ammonia is normal, then what is the answer? What is the answer? If ammonia is normal. If ammonia is normal, then what I will do? Methyl malonic aciduria, my dear boy. Treatment for methyl malonic aciduria is B12. Because methyl malonyl CoA is converted to succinyl CoA by B12. Okay, then right. So when ammonia is normal, I will look for urine for glucose. Urine for non-glucose reducing substances. Non-glucose is galactose and fructose. Non-glucose reducing substances. Non-glucose reducing substances. Okay. If non-glucose reducing substances present or absent. Present or absent. Non-glucose reducing substances. That is your galactose or fructose. If present, my diagnosis is galactosemia. My diagnosis is galactosemia. Galactosemia. If absent means, I will think in terms of aminoacetopathies. What are all the aminoacetopathies? What are all the aminoacetopathies? What are all the aminoacetopathies? The aminoacetopathies are your phenylketonuria, tyrosinemia, all those things are aminoacetopathies. Okay? Aminoacetopathies. Is it okay, my dear boys and girls? And finally, sir, how you will find out a non-glucose reducing substances? How you will find out a non-glucose reducing substances? How you will find out? Very, very simple. You do, what are all the things? One is Benedict's test in urine and another is dipstick test in urine. Dipstick test. Benedict test will find out glucose, galactose, fructose. Whereas dipstick test will find out only glucose. So, when will you suspect non-glucose reducing substance? The answer is very, very simple. When Benedict is positive, but dipstick is negative, then it is called non-glucose reducing substances. Either it can be galactose or it can be fructose. Galactose, the child will worsen immediately after birth. Child will worsen immediately after birth. Whereas fructose, which is present in fruit juices, the child will worsen after weaning. The child will worsen after weaning. That is by about 6 to 9 months. My dear boys and girls, definitely this approach to acute IEM will fetch you 1 mark. I repeat, you could not find this kind of simplified explanation in any of your books or classes. Right. So what is the answer? Is sepsis score is negative. Blood CSF culture did not grow any organism. So no skin lesions, no abnormal odor. So in multiple carboxylase deficiency, skin lesions are present. In glutaric aciduria and tyrosinemia, you will have abnormal urinary odor. In multiple carboxylase, it is tomcat's urine. In glutaric aciduria, you have sweaty feet urine. And in case of tyrosinemia, rotten cabbage urine. In case of tyrosinemia, rotten cabbage urine. And finally, methyl malonic aciduria, no abnormal urine odor, no abnormal urine odor, no skin changes. No abnormal urine odor or no skin changes. So this is with respect to inborn errors of metabolism and approach. I'll be giving you this PDF, don't worry. So this is approach to organic aciduria and approach to IEM. And let us go to this thing. What is this? So done. A 4-day-old newborn brought with sudden onset cyanosis and saturation drops to 60% on room air. The diagnosis is a 4-day-old newborn brought with sudden onset cyanosis and saturation drops to 60% on room air. So what is the diagnosis? What is the diagnosis? Answer, let me be waiting for your answer, my dear boys and girls. 4-day-old newborn brought with sudden onset cyanosis and saturation dropped 60% on room air. The diagnosis is A. Tricuspid atresia, B. Tetralogy of Fallot, C. Transposition of great arteries, C. Truncus arteriosus. So what is the answer? Let me be waiting for your answer. Transposition of great arteries. Akhil, you need to look into the ECG, my dear boy. Yes, what is the answer? Okay, done. So what is the approach to congenital heart disease? Let me concentrate only on cyanotic congenital heart disease. Okay? Let me concentrate on cyanotic congenital heart disease. Okay. Whenever you have cyanosis in a newborn, right? Okay. Whenever you have cyanosis in newborn. Okay, no one is answering. Let it be. So when you have cyanosis in newborn, the first thing is you need to do hyperoxia test. You need to do hyperoxia test. In that you will give 100% oxygen for 10 minutes. 100% oxygen for 10 minutes. And look whether SpO2 or PO2 increases or not. Okay. So when it increases, ECG you don't know, we'll take a class but not now. It's very easy, my dear boy, very easy. Since you have asked and since you are sincere, let me tell you a simple algorithm with respect to congenital heart disease. Okay? Right. So when SpO2 when SpO2 or PO2 increases, means it is called PAS. Hyperoxia test PAS. So PAS means what? It is pulmonary cause. Then pulmonary cause. If it is fail means hyperoxia test fail means oxygen saturation is not increasing despite giving oxygen. So what is the answer? It is fail means cardiac cause. Fail means cardiac cause. So when cardiac cause is when you have a cyanotic child with a failed hyperoxia test, that is fails to increase the oxygen saturation even after 100% oxygen for 10 minutes, it is cardiac cause. That is mainly right to left shunt. Right to left shunt. Then when this failed hyperoxia test, let me change the color even though my handwriting is bad. So failed hyperoxia test. Failed hyperoxia test means it is cyanotic congenital heart disease. Cyanotic congenital heart disease. In cyanotic congenital heart disease, we divide into two. One is reduced pulmonary blood flow. Another is increased pulmonary blood flow. Reduced pulmonary blood flow means the lung. Reduced pulmonary blood flow again is increased pulmonary blood flow. In reduced pulmonary blood flow means I will go for X-ray. I will go for X-ray. When X-ray, I will see. I will go for X-ray. One second. I will go for X-ray. So in X-ray, cardiomegaly present. In X-ray, cardiomegaly present. Huge cardiomegaly. I repeat, my dear boys and girls, it's a huge cardiomegaly. The only congenital cyanotic heart disease with a huge cardiomegaly is Epstein's anomaly. Huge cardiomegaly is Epstein's anomaly. Whereas when you have Epstein's anomaly, when you don't have our normal cardiac size, okay, normal cardiac size, then it can be due to normal cardiac size, then it can be due to two things. Let me tell you. Then you need to take an ECG. If ECG shows right axis deviation, it is tetralogy of Fallot. If ECG shows right axis deviation, oligemic lung. Oligemic lung means, very good, Akhil. So ECG shows right axis deviation means tetralogy of Fallot. If ECG shows left axis deviation means it is tricuspid atresia. It is tricuspid atresia. Remember, my dear friends, whenever you take an X-ray in failed hyperoxia test and whenever you find a large cardiomegaly, the diagnosis must be only Epstein's anomaly. Okay, it is an entrance MCQ. The child failed hyperoxia test and the lungs are black and you could not see the pulmonary vasculature, means that is called pulmonary oligemia, just like our Akhil told. In that case, take an X-ray. If X-ray shows a large, huge heart, it is a case of Epstein's anomaly. If ECG shows left axis deviation, the only diagnosis it must be tricuspid atresia. The only diagnosis it must be tricuspid atresia. Diagnosis is it must be tricuspid atresia. ठीक है अखिल? Okay. Again, this will fetch you definitely one MCQ, because this will fetch definitely one MCQ. ठीक है? Since Akhil asked me ECG, just 1 minute revision of ECG, just 1 minute. So how to revise? Okay, remember, normal axis is, what is this? Lead 1, lead 2, lead 3. Normally lead 1 will have a R wave like this, lead 2 will have an R wave like this, lead 3 will have an R wave like this. Then Akhil can ask me, why this? Because heart will move from the current, electrical waves will move from 11 o'clock to 5 o'clock position. Lead 1 is here, that is over the shoulder. Lead 2 is over the left hip, lead 3 is over the right hip. So when current moves towards one particular direction, that will have a positive R wave. Since current is moving from 11 o'clock to 5 o'clock position, that is towards where lead 2 is present, lead 2 is normal. So when lead 2 is more than lead 1, which is more than lead 3, you are getting normal axis. So this is called normal axis. Normal axis is R wave in lead 2 is more than lead 1 is more than lead 3. This is normal axis. This is normal axis. But whenever you have a left ventricular hypertrophy, so heart is here. When heart undergoes huge enlargement, what will happen? The left ventricle will grow towards your left axilla. Now current instead of flowing from 11 to 5, it always move towards the place where muscle mass is more. So instead of moving from 11 o'clock to 5 o'clock, it will move from 11 o'clock to 2 o'clock position. Since current is moving from 11 o'clock to 2 o'clock position where your lead 1 is present. So what happens here now? Lead 1 will be tall, lead 2 is little bit away from the flow of current. So lead 2 is small. But what happens to lead 3? Lead 3 is here, but current is moving towards this direction. So you will have a negative wave, or otherwise known as S wave. So this is called left axis deviation. What is called left axis deviation? Tall R wave, lead 1, and S wave, negative S wave in lead 3 is called left axis deviation. And finally, what is called right axis deviation? Here there is a right ventricular hypertrophy in this side. So current instead of flowing from 11 to 5, it will flow from 11 to 7 o'clock position. So what happens when it moves from 11 to 7 o'clock position? It moves towards lead 3. Now lead 3 will have a tall R wave, and it is quite away from lead 1, so that lead 1 will have a deep S wave. So what happened? This is called right axis deviation. Right axis deviation is tall R wave in lead 3 and deep in lead 3 and deep S wave in lead 1. This is called right axis deviation. Okay, this is called right axis deviation. Lead 3 is over right ventricle. This is called axis deviation. What happens in tricuspid atresia? In tricuspid atresia, you have absent tricuspid valve. As a result of which, absent or hypoplastic right ventricle When you have a hypoplastic right ventricle, invariably what is the ventricle that is left out? Left ventricle. That's why you have a left axis deviation. Remember, my dear friends, there is a rule of thumb. So what is called a rule of thumb? The rule of thumb is cyanosis. LAD means left ventricular hypertrophy. RAD means right ventricular hypertrophy. So whenever you have cyanosis along with left ventricular hypertrophy occur or left axis deviation, the only diagnosis is tricuspid atresia. Okay? That's it. Now let's see. What is this? Sudden onset cyanosis and saturation drops to 60 on day 4. Because by day 3, ductus arteriosus closes. So cyanosis you have. Look here. Is this left axis, right axis, or left axis, right axis, or normal axis? Let me say, okay, this is lead 1, this is lead 3. Just look here. Which has got tall R wave and which has got deep S wave? I am going to wait for your answer. Which has got tall R wave and which has got deep S wave? Waiting for your answer, my dear friends. Many of you are there waiting for your answers. Now tell me in this, which has got lead 1. So Akhil, when you have tall R wave in lead 1, look at this tall R wave and deep S wave in lead 3. So current is moving this direction, my dear boy. So you have left ventricular hypertrophy or left axis deviation. I told you the rule of thumb is cyanosis plus left axis deviation plus newborn. The only condition that can cause is tricuspid atresia. Only condition that can cause is tricuspid atresia. Okay, my dear boy. Look here. So what is the answer? Cyanosis is there. Left axis deviation is there. Without doing anything, without an echo, the diagnosis is tricuspid atresia. People used to say, okay, people used to, very good, my dear boy. Plus cyanosis you need to mention. People used to say the only cardiac disease in the newborn period that doesn't require echo, a simple ECG can give you a clue, is tricuspid atresia. Okay, I am going from this fourth question. Okay, done. Let me go to the fifth question. What is this? A 5-year-old child, okay, a 5-year-old child brought with low grade fever for 4 weeks, along with the difficulty in getting up from the bed and some skin rashes. His total and differential count were appropriate for age. CPK levels are 1000 international units. The next best step is, and they had given you one picture: MRI thigh, muscle biopsy, electromyogram, MRI thigh. What else? And I can say, okay, is getting repeated. So let it be. What is the answer? MRI thigh, muscle biopsy. Let me say, okay, ANA levels. So what is the answer? Waiting for your answer. What is the diagnosis? And tell me what to be done in this case. What to be done in this case? What to be done in this case? Tell me, my dear boys and girls, what is the answer? Okay, let me proceed. So this child, JRA, juvenile, it should be called as JIA, my dear boy. It is called juvenile rheumatoid arthritis. It is called juvenile idiopathic arthritis. So the correct term is JIA. Okay, done. So look at this. What is this? There are hyperpigmented things in the knuckles. What is this? There are hyperpigmented things in the knuckle. What is this? I am waiting for your answer. What is this? Waiting for your answer, my dear boy. What is this? Very good, Akhil. It is called Gotran papule. So what is the diagnosis, my dear boy? The diagnosis is, so what is the diagnosis? What is the ringworm? What is the diagnosis, my dear boy? It is called, what is the diagnosis? This is not ringworm, this is marker. So what is the diagnosis? This one. So this is called Gotran papules. So what is the diagnosis? It is called JDM, juvenile dermatomyositis. This is called JDM. This is called juvenile dermatomyositis. Dermatomyositis. That's why What is called dermato skin manifestation? Myositis manifesting in the form of elevated CPK and manifesting in the form of weakness, that is difficult to get up from the bed. This is called juvenile dermatomyositis. So, what is juvenile dermatomyositis? What is juvenile dermatomyositis? You have definitely, what is the criteria? The criteria is, one is definite skin involvement, definite muscle biopsy, okay, definite skin involvement. Let me say again, my dear boy, the child is having fever. One, the child is finding it difficult to get up from the bed. So what does it mean? Proximal muscle weakness. The child is having some skin rash. CPK is elevated. Creatinine phosphokinase is elevated, which is a muscle enzyme. So it is getting released from the muscle. So skin manifestation in the form of Gotron papules, that is given here. That is dermatitis, and myositis is manifesting as proximal myopathy and elevated CPK levels. So this is a case of juvenile dermatomyositis. Dermato means skin manifestation. What are all the skin manifestation? One is pigmented skin in the knuckles, and pigmented skin in the eyelids. Pigmented skin in the knuckles is called as Gotron papules. That is what you have seen here, Gotron papules. And in the eyelids it is called heliotrope rash. So two skin manifestations of juvenile dermatomyositis, one is Gotron papules, another is heliotrope rash, along with that muscle involvement. So my dear boys and girls, how muscle involvement can be identified? One is clinical. Clinical means what? Proximal myopathy. Proximal myopathy means what? If it involves the upper limb, you will find it difficult to comb or difficult to raise your hands above the level of the shoulder. If it involves the lower limb, you will find it difficulty to get up from sitting to supine or supine to standing position. Proximal myopathy. This is clinical. Wait, my dear boy. Clinical. Second one is muscle enzyme. Wait, my dear M and Akhil. Muscle enzyme means elevated CPK levels. Second. Third one is, you can do an electromyogram and look for reduced compound action potential. Of in EMG, because muscle is the one which produces the amplitude of the wave. And finally, you can do a muscle biopsy. My dear Akhil and my dear M, look here. You need to have either one of the skin manifestation. You need to have either Gotron papules or heliotrope rash, along with either proximal myopathy or elevated CPK or abnormal low potentials in BMG or biopsy findings. Remember, all these things are invasive. Methods. That's why dermatomyositis, instead of doing all these things, they had preferred for, I repeat my dear boys, they had preferred for MRI thigh. When you have a skin manifestations like Gotron papule or heliotrope rash, along with the Gotron papule or heliotrope rash, along with elevated CPK, directly do MRI thigh. In MRI thigh, you will get hyperintense signals. Then the diagnosis of Juvenile dermatomyositis is confirmed. That's why the invasive clinical is okay, muscle biopsy is okay, but they are all less specific. And remember, biopsy is invasive. EMG a procedure you need to do. Instead of all those things, the entire spectrum of these things is getting replaced by MRI thigh. Proximal myopathy in the form of difficulty in standing or getting up, along with elevated CPK, along with skin lesions, directly go for MRI thigh. I repeat, my dear friends, MRI thigh is the investigation of choice at present for a suspected case of juvenile dermatomyositis. Juvenile dermatomyositis. Remember, almost 95% kids will have ANA positivity. ANA positivity. Okay, right? So little bit difficult, na? Little, because you are going to give it for INICET, na? So answer is you have never thought about this answer, no? So MRI thigh. Remember, my dear friends, it is always, medicine is always an ever changing subject, ever improving subject. The one which is present today will not be present tomorrow. Some other new investigation will come and it will replace you. At present, currently, MRI thigh is the investigation of choice. That is for your INICET. When you concern with the NEET, you need to think in terms of Gotron papules or heliotrope rash. Heliotrope rash. Okay? Shall I go for the next one? Shall I go for the next one? Okay, let me go. A 7-month-old child presents to the OPD with classical, clinical and radiological features of rickets. The infant had alopecia and epidermal cyst. Her calcium and phosphorus levels are low. PTH is elevated or low. Okay, then. Thank you, doc. Okay, calcium and phosphorus levels are low. PTH level is elevated. Level of 25D is normal. 125D is extremely elevated. What is the treatment of choice? I will wait for about a minute so that find out what is there in the X-ray and find out what is the cause for this rickets and tell me the answer you need to choose among this. I'll wait for about 30 seconds from now. Mohit, you opted for D, my dear boy. Let me see. Mohit has opted for D. Some other. Waiting for Akhil. Another M. Answer. Looking for that. Your chat box in my YouTube. Okay, done. Remember, my dear friends, let me explain you right now the approach to rickets. I repeat, the approach to IEM, the approach to cyanotic congenital heart disease. I think I had made it easy for you, so that definitely one clinical based questions will come now. And now approach to rickets. Shall I proceed, my dear boys and girls? Now what are all the findings in this X-ray? So there is cupping, point number 1. There is fraying, point number 2. Third point, one is cupping, second one is fraying. Third point is widening of the growing end. So what is this? You have cupping of metaphysis. You have fraying of metaphysis, cupping, fraying, and finally widening of growing end. All these things together goes in favor of rickets. Anyone knows? So for the next 2 minutes, we are going to discuss in detail, a bird's eye view on approach to rickets. Let's see. Approach to rickets. Let's see. Done. So approach to rickets. Whenever you have rickets, the first thing you need to look for is phosphorus levels. Phosphorus levels. Before that, once again. Remember, rickets is mainly based on the level of phosphorus rather than level of calcium. Okay, the first thing is, the first thing is you need to go for pH. You need to go for pH, blood pH. Blood pH. If blood pH is low, it is due to renal tubular acidosis. Why? In case of proximal renal tubular acidosis, you will have low phosphorus. Whereas in case of distal renal tubular acidosis, you have low calcium. As a result of which, you will get rickets in renal tubular acidosis. First point. Second point. Then you need to look for phosphorus levels. Phosphorus level is high. If phosphorus level is high, invariably simple, very, very easy. Parathyroid hormone is the one which what is the role of parathyroid hormone? Parathyroid hormone secretes phosphorus from the proximal convoluted tubule. So when blood phosphorus levels are high, it means that your parathyroid hormone is low. So when phosphorus levels are high, it can be due to low PTH. Low PTH means hypoparathyroidism. The answer is hypoparathyroidism. Thyroidism. Okay. If in the case of high phosphorus, okay, when parathyroid hormone is very high, it means you are dealing with chronic renal failure. This is called secondary osteodystrophy, chronic renal failure. Second. Third, if the phosphorus is low, then you need to look for phosphorus is low, then you need to look for three things. 1, 2, 3. You need to look for three things when the phosphorus is low. One is 25 OH D3 levels. When 25 OH D3 level, which is the storage form, it is called nutritional rickets. Then you need to look for 125 dihydroxy D3. So 25 hydroxy D3 is storage form. 125 dihydroxy D3 is active form. It can be either low or it can be 125 dihydroxy D3 or it can be high. When 125 dihydroxy D3 is low, it means type 1 renal rickets. What do you mean by type 1 renal rickets? Your 25 hydroxy D3 is converted into 125 dihydroxy D3 with the help of 1 alpha reductase. When 1 alpha reductase is absent, then your 125 dihydroxy D3 will be low. Second, when your 125 dihydroxy D3 has to act on the receptors present in the intestine, receptors present in the bone, receptors present in the intestine, then what will happen? Your active form of vitamin D3 will act. When the receptors are resistant, 125 will be high. So this is called type 2 rickets. Rickets. I say better not to use this term. Type 2 rickets. When 125 dihydroxy D3 is low, it is called type 1 Vitamin D dependent rickets, VDDR type 1. Vitamin D dependent rickets type 1 is due to absence of 1-alpha hydroxylase. Whereas when the receptor is mutated, your 125 dihydroxy D3 will be high. This is called VDDR type 2. This is called vitamin D dependent rickets type 2. In which 125 dihydroxy D3 is high. 125 dihydroxy D3 is high. This vitamin D dependent rickets is associated with alopecia. Okay, remember, in all these three rickets, parathyroid hormone will be high, because your calcium may be low, phosphorus may be low, which can stimulate the parathyroid hormone. I repeat, when parathyroid hormone levels are high, you need to look for 25 OH. You need to look for 25 OH D3. When 25 OH D3 is low, it is called nutritional rickets. Then if it is normal, go for 125 OH D3. When 125 OH D3 is low, vitamin D dependent rickets type 1. Whereas when 125 dihydroxy D3 is high, it is called vitamin D dependent rickets type 2, which is associated with alopecia. Remember, again simple, when rickets usually is a disease of growing bones, nutritional rickets usually occurs after let me say 6 months to 1.5 years or 2 years onset. When rickets onset less than 6 months, always think in terms of VDDR type 1. Always thinks in terms of VDDR type 1 or type 2. Simple way, doesn't mean that you need to think in terms of so many complex things. When you have onset less than 6 months, think in terms of a VDDR type 1 or 2. Alopecia present, 2 alopecia absent type 1. Rickets 6 months to 1.5 years, always it is nutritional rickets. So what is the treatment? Nutritional rickets. No stars regimen now. Now, what is the thing you need to do? Vitamin D3, 60,000 units. 60,000 units weekly once. Into 8 weeks. This is one regimen. Another regimen is vitamin D3 oral, 2000 international units per day into 8 weeks. At the end of 8 weeks, you need to take an X-ray knee. If you take an X-ray knee, you will find out this one. What is this? Look at this. You will find out this one. What is this? You will find out this one. Look at this. Here in this X-ray, in the first X-ray, pre-treatment X-ray, the growing end is, there is cupping, fraying, widening. But as soon as you start your vitamin D3, you could see something specific here. These are all my clinic cases. What is this? A ring of white thing that is seen in the growing end. What is this? This is true thing you have seen in your book. This is the case which we had seen. This is called zone of provisional calcification. This is in case of true nutritional rickets. You will get this zone of provisional calcification. And this is the treatment for nutritional rickets. Again, what is the treatment for VDDR type 1? What is the treatment for VDDR type 1? There is, you need to give vitamin, you need to give activated, that is activated 125D3, that is you need to give your cholecalciferol along with phosphorus. Whereas in VDDR type 2, it is resistant now, so extremely high doses of vitamin D3, despite that it won't work. So nutritional rickets are in 6 months to 1.5 years. Less than 6 months, if you see any case of rickets, invariably it is VDDR type 1 or 2, which won't respond. VDDR 1 may respond to physiological doses of vitamin D3, activated vitamin D3, whereas VDDR type 2 won't respond, and it will be associated with alopecia. That's it. And finally, what is called X-linked hypophosphatemic rickets? What is called X-linked hypophosphatemic rickets? Remember, in vitamin D dependent rickets, in nutritional rickets, low 25-OH-D3 with elevated parathyroid hormone, low 125-DH-OH-D3 with elevated parathyroid hormone, high 125-OH-D3 with elevated parathyroid hormone. Almost all cases of nutritional rickets or vitamin D dependent rickets all are associated with what? Low calcium, low phosphorus and a high parathyroid hormone. All occurs in these 3 scenarios. But whenever you have a combination of low phosphorus, normal calcium, and normal PTH value, the diagnosis is X-linked hypophosphatemic rickets. This is often asked. Why, you can say, why in X-linked hypophosphatemic rickets parathyroid hormone is not raised? Remember, in this scenario, in nutritional rickets, VDDR type 1 and VDDR type 2, the calcium is low. It stimulates the parathyroid gland. This parathyroid in turn absorbs calcium and excretes phosphorus. So phosphorus is low. Whereas in case of X-linked hypophosphatemic rickets, the predominant affected thing is low phosphorus. This low phosphorus in turn will not stimulate the parathyroid hormone. Parathyroid hormone will be secreted only in the presence of hypocalcemia and not will be secreted in the presence of hypophosphatemia. Parathyroid hormone doesn't bother about the blood levels of phosphorus. That's why a case of the triad of, let me say, what is the triad? The triad of, very, very important, my dear boys and girls, the triad of rickets, low phosphorus, normal PTH, unless otherwise proved, this is a case of X-linked hypophosphatemic rickets. This is a case of X-linked hypophosphatemic rickets. Very, very important. So in this case, what happens? PTH is elevated. Your level of 25D3 is normal. So this is nutritional rickets. 125 is extremely elevated. If it is low, VDDR type 1. If it is high, VDDR type 2. So this is a case of vitamin D dependent rickets type 2. What is the treatment? Starch therapy is mainly meant for nutritional rickets previously. Right now we are not using it. Still, if the complaint is poor, you can rely on starch therapy, in which you will give either 1.5 lakhs or 3 lakhs of vitamin D IM. Previously 6 lakh international units, but it is not followed right now. Oral phosphorus and calcitriol may be in cases of what? VDDR. Okay, VDDR. Okay. Oral phosphorus and calcitriol in any form of rickets. Therapeutic dose of calcitriol means 125 dihydroxy T3 along with dietary calcium in case of VDDR type 1, and extremely high doses of calcitriol with calcium in case of VDDR type 2. And finally, when you give phosphorus, invariably it is a case of X-linked hypophosphatemic rickets. That's it. In the 10 minutes, we have completed enough about an approach to rickets. Don't worry, you just sleep. Revise it tomorrow. You will get a better idea tomorrow too. Don't worry. So, zone of provisional calcification is a question. And finally, so let us wind up our session with this. Almost 2 hours are over. A 3-year-old child has been referred to the tertiary hospital with the following features. 2 episodes of pneumonia in the last 6 months. Proven radiologically with nematocele in the second episode and recurrent skin abscess needing IV antibiotic. On examination, his face is dysmorphic, pruritic markings, healed scars of abscesses are seen. What is the next level of investigation and what is the photo that is given here? So what is this? The child having recurrent abscess, pneumonia, nematocele formation, multiple abscesses, multiple pruritic marks. And this is what is this? And what is the next level of investigation? Dealing with a case of primary immunodeficiency. What is this case? Primary immunodeficiency, a 1.5 session were discussed in detail in our PW app. What is this? So anyone? So this is a case of disseminated molluscum contagiosum. Disseminated molluscum contagiosum can occur in 2 cases. One is HIV and another is hyper IgE syndrome. So what are all the manifestations of hyper IgE syndrome? So what is this? Diffuse molluscum contagiosum. It can occur in 2 diseases. One is HIV and another is hyper IgE syndrome. So what about hyper IgE syndrome? What are all the things you need to have? Hyper IgE syndrome is characterized by this following. One is multiple painless abscess. That multiple painless abscess is called as Job syndrome. One. Second point is called Job syndrome. Second point is you have retained primary teeth. So that you will have double row of teeth. 1 row temporary and 1 row permanent. Third, you have atopic dermatitis. Or asthma. Why? Because hyper IgE syndrome is characterized by elevated IgE and elevated eosinophils. And finally, abnormal faces. This we used to call it as FATED. The clue for hyper IgE syndrome is FATED. FATED. F stands for abnormal phases. A stands for A stands for multiple painless abscess. T stands for double row of teeth. E stands for elevated eosinophils and IgE, and T stands for atopic dermatitis. So this is a case of hyper IgE syndrome with this pentad: abnormal phases, abscess formation, painless abscess, double row of teeth, elevated eosinophilia and IgE, and then dermatitis. So what is the investigation of choice? Investigation of choice is IgE level. Usually will be more than 2000 international units. But right now genetics we have, in which you will use either DOC mutation or STAT mutation. Okay. And what is the answer? That is disseminated molluscum contagiosum occurs one in HIV, another in hyper IgE syndrome. So the answer is serum IgE levels. Serum IgE levels. Nitro-blue tetrazzolium test is for chronic granulomatous disease. Again, those things are discussed in detail in our PW sessions. Okay. So with this, almost 2 hours are gone. Thanks for your patient listening. All the best for your examination. We will be posting you many pediatrics question on daily basis from tomorrow in our Telegram group also. With this, let me finish our topic for today. Thanks for your patient listening. Bye bye. Good night.